Basically, dydrogesterone was introduced to me by my teacher in 1995 when I was resident. When I started my private practice, I had used dydrogesterone in few indications. But in 2001, when I studied the report by Professor Alzebi, Dr. Raj Raghupati and Julia Bartho on threatened abortion, I am delighted to use this molecule in cases of threatened abortion. And basically this molecule is retroprojesterone. It is derived from plant source, discoria vallis or diosgenin is the molecule, and from that plant source they are manufacturing Procata, and ultimately tablet is derived which has got only oral available progesterone in the market. I had done review research in usage of progesterone in infertility in first trimester as a luteal support, and that is published in Open Access Journal in Michigan publication in 2016. It is a review article, and on that article I had done review of all the available molecule of progesterone in the market, and surprisingly at the end I found little bit higher age on using of dydrogesterone compared to all different variety of progesterone when you talk about use of progesterone in first trimester. Basically, dydrogesterone molecule was introduced to me by my teacher when I was doing my residency in BJ Medical College. Then it came to private practice in 1995. I am using dydrogesterone for subtle indications, but when I read the paper in 2001 in the 9th World Congress in Hong Kong, there are professors Alzibei, Julia Barthos and Professor Raj Raghupati. They had done marvelous study on the uses of progesterone molecule in cases of threatened and recurrent miscarriage. Then I had done review in 2016, and that review article was published in Open Access Journal in Michigan publication on the study of usage of progesterone in first trimester in cases of infertility. What I found that this molecule, the dydrogesterone, which is a retroprojesterone, has got more affinity for the progesterone molecule, and it is the only available dydrogesterone in market, has got little bit higher age compared to all different varieties of available progesterone in the market in prevention of threatened and recurrent miscarriage. I am since using 2000 this molecule, and I had done study of usage of progesterone, dydrogesterone as a molecule in cases of threatened abortion. 460 cases I had done study, and I had found that 67% of my patient, the pregnancy was salvaged. There is no threat in that of pregnancy. So, I have got very good experience compared from 2001 to 2019. Basically, I am using dydrogesterone in 3 indications. Indication number 1, threatened miscarriage. Indication number 2, recurrent miscarriage, and indication number 3, IVF. Let us go one by one. What we mean by threatened abortion? It is a threat, that is bleeding coming per vaginum when there is yolk sac is more than 5 weeks, fetal heart is there when there is 7 weeks of pregnancy, there is a live embryo, and there is only threat, there is no abortion, just threat. Cervix is closed. In this type of cases, we are giving dydrogesterone in 40 milligram dose. The study which has came in market in 2001, they had done 10 milligram BD dose, but that study has still proven that if you give incremental dose of dydrogesterone, there are more and more progesterone receptor available, because one of the indication, one of the thing by which there is bleeding occurs is lack of progesterone or lack of progesterone in the environment of the uterine milieu. So, if we give higher doses, it will give a stoppage of bleeding, that is 40 milligram state, and then 10 milligram BD, still bleeding stops, and if everything is good, you can continue with this dose up to 12 milligram when there is full blown placenta, and that placenta gives enough amount of progesterone to the nurturing baby. Second indication is recurrent pregnancy loss. By definition, it is an abortion which occurs before 20 weeks of gestation. Recently in literature, we had found that one of the key indications or key factor by which there is recurrent pregnancy loss is inadequate secretion of progestogens from the uterine endometrium. And if we see, we all are here in this world because our mother has generated enough amount of endogenous estrogen, progesterone, to nurture the pregnancy. And progesterone is the essential hormone for making baby out of the womb. If there is insufficient amount of progesterone available into the uterus, then the pregnancy will not able to salvage. So, for good pregnancy to occur, we must require pregnancy conducive endometrium. The endometrium which is rich in endometrial stabilization, endometrial maturation and good for embryo to implant. What we mean by embryo maturation? If we see at the time of implantation window, if you take the cut section and that cut section if you see on electron microscope, you will see beautiful pinopores, mushroom like pinopores are there ready for embryo to anchor. Second, endometrium stabilization. This type of fluffy endometrium should be stabilized with the base with integrins, and that integrins are alpha V beta 3. Third thing is good for implantation. If you see at the time of pregnancy conducive endometrium, endometrium has got good affinity for embryo to anchor. We all know that we are going into the endometrium either by the tube at the blastocyst level. So, we are jumping into the endometrium, or by IVF we are putting embryo into the endometrium into the cavity by just pushing it. So, by both the way we try to put the embryo at the level of maximum implantation potential. So, all the embryo should come at the level of maximum implantation potential point. Either you are putting from the natural cycle, it comes from tubes and jumping into the endometrium, or via cervix if you are putting into the cases of IVF. At that time embryo should go into the maximum implantation potential point. At that point there is a good amount of pinopores, there should be good amount of integrins, that is alpha V beta 3, and study has shown that embryo and endometrium has got affinity like attraction, like sometimes they found endometrial glue like structure, that is osteopontin, and they will adhere. If you see just in a good path of endometrium, if good embryo is working, good embryo is going, what will happen? It will anchor. The endometrial cell will engulf that embryo, and we are putting ourselves by eroding the endometrium, then that erodation is occur by phagocytosis, which is done by syncytotrophoblast and cytotrophoblast, and then we are putting ourselves into the endometrium. So, if everything is good, that is known as pregnancy conducive endometrium. And so, for pregnancy conducive endometrium, three things must be there: endometrial stabilization, endometrial maturation and good endometrium ready for implantation. If all these criteria met, then pregnancy will continue. But if you see in nature, what will happen? We all are born with 50% chromosome from our mother and 50% chromosome from our father. Sometimes our mother consider that 50% chromosome which we acquire from our father as an antigen. Against that antigen, body will develop antigen antibody reactions, and in any type of antigen antibody reaction there is activation of T lymphocytes, and that T lymphocyte has got two different pathway, Th1 pathway and Th2 pathway. Once there is activation of Th1 pathway, what will happen? There is abortion. But if there is activation of Th2 pathway, pregnancy will continue. Now, let us see what is Th1 and Th2. In Th1 type of activation, there is three different pathways. Number one, there is formation of harmful cytokines like 2, 12 and 22. There is formation of symmetric antibody, just like crisscross or locking mechanism. Step 3, there is formation of natural killer cell converted into lymphokine activated natural killer cell. And believe me that lymphokine activated natural killer cell has got more cytotoxicity compared to natural killer cell. When all these three segments or all these three responses are active into the embryo, there is abortion. But if this type of things to happen in our body, nobody in this earth would survive and come here. That's why body has developed positive immunomodulation that occurs by three positive response. Number one, Th2 activation. In Th2, we have got protective cytokines like 3, 4, 5, 6, 10 and 11, and there is formation of asymmetric antibody, there is no lock and key mechanism, and decrease in the formation of natural killer cell. If there is activation of Th2 cytokines, if you see the cell wall, it has got lots of holes and there is distraction because there is activation of complement cascades. So many times what happens when woman doesn't know that she was pregnant and she had got abortion. But in our body, when there is Th2 cytokines are active, it means our body has got positive immunomodulation, it has created antibody against antigen antibody reaction has not occurred into the uterus and the baby is nurtured in utero. Clark et al. Has done study in 1999 and they can see that why my mother has rejected me. They had done the immunological modules of that embryo or abortion and what they found. The progesterone receptor was very less compared to the natural cycle person. Julia Bartho has done study in 2001 in all the volunteers in which they found that when there is continuation of pregnancy, more positive receptor cells are there in body, but when there is abortion, less P receptor positive cells are body, number one. Number two, then they had done study on two uteri of a mouse. In one uterus, there is continuation of pregnancy and second uterus they had injected RU486 or mifepristone, that is antiprogesterone, and what they found, when they use antiprogesterone, there is abortion. When they used nothing but natural progesterone is there is continuation of pregnancy. Study number 2. Study number 3, that seen that if you give more progesterone receptor, whenever there is good endometrium, the progesterone receptors are there into the lymphatic system of the uterus. So, they had done study on use of increment of doses of progesterone and see how progesterone positive receptors are there on the uterine endometrium. And surprisingly, they found that increasing dose of progesterone will give increased progesterone receptor into the uterine endometrium. So, by three things they had proven that progesterone is utmost essential for the endometrium to become conducive. And there are studies which shows that improper decidualization or suboptimal decidualization is not good for embryo to implant into the endometrium. So, for good conducive endometrium, we must require progesterone. For the progesterone to occur into the endometrial wall, there is PIBF, that is progesterone induced blocking factor. If PIBF is more in the endometrium, there is more affinity of embryo to enter into the endometrium and pregnancy become continuous. The study says that if you use dydrogesterone will directly give increase in PIBF. So, if we have got increase in PIBF, there are positive immunomodulation, increase in the progesterone receptive cells, increase in the production of protective cytokines. There should be no symmetric antigen antibody reaction, no activation of complement cascade, no destruction of the cell wall. The natural killer cell formation will be decreased. So, there are three positive response of the users of dydrogesterone to make the pregnancy conducive endometrium and to make proper decidualization for embryo to anchor into the endometrium and pregnancy will continue. So, this is my second indication. First one is threatened abortion, second is recurrent pregnancy loss and third one is IVF. When we are doing IVF, we are doing the catastrophization of the hypophysis or pituitary by giving gonadotropins, which will go and anchor into the pituitary and block the hormone production. So, FSH and LH are not produced from the pituitary. After this level, we are giving injectable gonadotropins from the outside, making very good cohort of follicle by controlled ovarian hyperstimulation. Then at the time of pickup, we are sucking ovum from the ovary via the pickup needle. But believe me, we are not sucking only the ovum, we are also sucking the granulosa cell, which is the precursor of corpus luteum, and that corpus luteum produces progesterone to nurture the pregnancy. So, in IVF, as we are doing down regulation, we are doing pickup, so we have to give progesterone support or luteal phase support in form of nurture the embryo, because as I told, because of progesterone we all are here into the in this exterior or into this world. So, in IVF we have to use progesterone either in form of intramuscular, vaginal or oral. Two giants are in market, micronized progesterone and dydrogesterone. But if you see, mother of both this progesterone is diosgenin, and diosgenin is coming from the plant source discoria villosa. From that prokaryota, if you go in a path of micronization of the molecule, then it becomes micronized progesterone. If you take this molecule into the UV path and break the molecule and make the retroprojesterone, then it becomes the dydrogesterone. But the beauty of dydrogesterone molecule is it is bioavailable, oral, and it affects at the site. For micronize, there are different ways. If you take orally, there is very little absorption because first bypass is liver. If you put the drug at the site into the vagina, it becomes messy. Sometimes it causes discharge and patient says that there is bleeding per vagina. So, these two giants are in market and we have to use judiciously. That is why in FOXY, before 5 years, we had made a FOXY statement of using of progestogen in LPD. And I am happy that I am part of that study, part of that formulation of guideline, and what we had done that we had specified the dose of usage of progestogen in different indications. If I want to use in threatened miscarriage, I will use as a 40 milligram state, then 10 milligram BD, still bleeding stops. If I want to use progestogen in recurrent pregnancy loss, I will use 10 milligram BD till the placentation or till 12 week. If I want to use the same molecule in IVF, that is 10 milligram 3 times a day. And recently we have got Lotus 1 and Lotus 2 study. Lotus 1 is comparison of micronized vaginal progesterone 600 milligram versus dydrogesterone 30 milligram. Lotus 2, in which we had done study of 30 milligram dydrogesterone compared with micronized progesterone gel. It is a very huge study. It is a double blind, double dummy study. So, presenter also not knows what he had given to the patients, and patient also not knows how they are doing the studies. But this double blind, double dummy study is in Lotus 1 only. In Lotus 2, we can't make the gel, we can't make the dummy gel. So, it is a double blind study in which what we had found that micronized compared to micronized progesterone either in a form of gel or capsule, dydrogesterone has got little bit of higher age, and at present the live baby rate is 40 plus. 40 babies are more born in arm of dydrogesterone compared to micronized, and these babies are doing well in the. If you see the dydrogesterone molecule in markets is last 6 decades. Until date more than 8 million or 9 million baby are delivered by using dydrogesterone. Until date the congenital side effects are comparable with the normal population. If we talk about the recent study which is done by George Grisinger, Lotus 1 and Lotus 2, all the babies which had delivered has got congenital malformation rate is less than 1%. But if we see the treatment TEAE, that is treatment endorsed adverse effect, they have got some adverse effect in form of neonatal jaundice, respiratory distress, low birth weight and congenital heart disease. If you compare the number of congenital heart disease, they have got 8 patients in dydrogesterone group and 11 patients in micronized progesterone group. But if you compare both this group result, it is comparable with the normal population which can go for congenital heart disease. So, for safety, there are little bit studies, no great trial available, but if you see the safety profile compared to harm, there is more beneficial effect seen in the society. You can't use this dydrogesterone or progesterone molecule in patient who have got cholestasis or liver problem. Believe me, in normal pregnancy, normal healthy woman, if you give progesterone, it won't work. When there is deficiency of progesterone, particularly in cases of threatened miscarriage, recurrent miscarriage or IVF. In IVF, we are lacking of progesterone because we are sucking out the granulosa cell, which is precursor of corpus luteum, and corpus luteum ultimately forms the placenta. So, looking by safety, till date no major study says that dydrogesterone molecule is not safe, but looking at the benefit compared to harm is little bit more.